I'm going to talk about three areas of my work. Thank you for the introduction and mentioning both the book, Just Medicine and Just Health. I'm going to talk about how each of those may affect Dallas County and the city of Dallas, and then Just Nation. So I hope to move increasingly and progressively larger in the scope of my comments, and then discuss your role perhaps in each of those areas. So it's my understanding that we can agree on the definition of health equity, that everyone has a fair and equal opportunity to be healthy. Not necessarily that everyone's outcome is healthy, but that everyone has the opportunity to be healthy. And because I am a lawyer, the focus of my interventions, or the focus of my efforts to accomplish health equity, have to do with justice, have to do with law. And thereby, on the right, you see the definition of eliminating unjust, unfair, and avoidable obstacles to the opportunity to be healthy as the focus of my of my comments. Now, I was asked specifically to talk about substance use and mental disorders, particularly the opioid issue that is facing the nation, and of course, facing Dallas-Fort Worth. And I'm going to do so by starting with a story from the Just Medicine book. Stick with me for a second, because this is a personal story. It takes a minute or two, but you'll see the relationship. And I hope it will bring to your thinking some ways in which you haven't thought about the opioid problem before. You see here the Lyft logo, and that's because I am a wannabe marathoner. I've run 2 marathons. That's probably all I'll ever run. But when I do, I don't run to the beginning of the marathon or the beginning of my training runs. I take a Lyft. And on one particular day, not too long ago, I was taking a Lyft to the start of my training run. That day was an 18-mile training run. For me, that's a lot. When I was in high school, I was a sprinter. When I was in college, I was a sprinter. So everything I did was over in fewer than 60 seconds. So this was a day I was very preoccupied. I called the Lyft. I got into the Lyft. It was dusk at the very beginning, not dusk, the very beginning of the day. So it was a little, the sun hadn't risen yet. And when I got in the back of the Lyft, the driver looked at me with a curious expression and said, "Oh, I'm not going to be able to take you to your destination." Now, my destination was about 6 miles away. It takes about 6 minutes to get there. And so I didn't think anything of it until he actually said to me, "I want you to get out of my car." At this point, because I am a woman of a certain age, my hackles went up, and I imagined that there was something about me personally that he didn't like, because he did answer the call. He didn't know where I was going, and it was 6 minutes away. And my Lyft account was current, so I could pay for the ride. At that point, I became a little bit indignant, a little bit arrogant, and I said, "Oh, yes, you will take me." And we obviously had no meeting of the minds. And so he locked his door and started driving away. So at this point, I'm petrified. I bang on the door. He does let me out. And I'm angry, thinking of ways that I could retaliate. Why this came to mind, I'm not sure. But I walked around his car and resisted the urge to key his car and simply opened every one of the doors. This is a meaningless retaliation. It was my way of gaining control over the situation. I went on with my day. I completed my run. I was not pleasant to my family, I will say, because something was amiss. Something was bothering me about that encounter, and it affected my emotions. It affected my thinking. It affected my relationships all throughout the day. Fast forward to, that was a Saturday, Monday morning, when I'm on my way to work now. I'm dressed for success. I get into another Lyft, and this driver looks like me. And so I say to this driver, "Is there anything I can do?" I experienced, and here is the important part of my interpretation, I experienced racial discrimination last Saturday in a Lyft. Now, what gave me that clue? Did this driver who wouldn't take me to the beginning of my run call me the N-word? He did not. Did he use any other epithets? He did not. but he communicated to me that there was something personal about me that he did not like and therefore would not take my ride. And I immediately processed all of the information that I have gotten in the years that I have lived in the United States of America, my upbringing, my gender, my religion, my ethnicity, my mental ability, my age. All of this came into play to convince me that he was racially biased towards me. Well, the next important part of the story is that the driver of this second car told me to call the dispatch. I did, and the person who answered the phone had a very deep Southern drawl. Now, you did not hear in my introduction, but it's true. I lived in Virginia for 10 years. And so this drawl was recognizable to me. It wasn't from Alabama, Mississippi, or Louisiana. It was a Virginia drawl. And again, my experiences told me that things were going to get worse before they got better. In fact, I could not have been more wrong. Although I assumed this person was a bigot, I was wrong. They instead heard me stumble over my story about the Lyft driver who would not take me where I wanted to go, interrupted me, and said essentially these words to me: "Ma'am, this is an emergency," because I had called the emergency dispatch without an apparent emergency. Secondly, he said, "Ma'am, no one deserves to be treated as you were." And thirdly, he said, "I will stay on the phone with you all day if I must to make it right." So immediately, the man that I thought was a bigot, because I had stored social group knowledge, I had identified his voice with a group, I had retrieved the stereotypes in my experience, I had accessed those stereotypes, and it influenced my decision and my conduct about how to act towards him. That is called implicit racial bias. And my point in telling you the story about myself is to convince the audience that is hearing me that all of us are subject to implicit racial bias, myself included. The research tells us that unconscious bias affects disparities in health, in healthcare, and I dare say in policymaking, in education, in every sphere of our lives. Now, if I had more time to talk just about the book, Just Medicine, what you would hear me talk about is the specific influence that this kind of bias has on the clinical encounter. That is, racial biases affect the length of time that doctors talk to their patients, the eye contact that they make, the kind of information they give, and the other way that it affects the clinical encounters that patients have biases too. You'd hear me talk about this in terms of how physicians and patients interact. But instead, I want to talk to you today about how implicit racial bias has impacted our historic and current responses to the opioid epidemic. For this, I will divide the opioid epidemic in the United States into three epochs, three historical periods. Opioid first affected the United States population during the period from the 1860s to the early part of the 20th century. We don't know exactly the number because records were not kept, but we do know that approximately 100,000 people were affected, and that during that epidemic, we were able to successfully treat and eliminate opioid addiction with policies that were directed at the population that was affected. Important to our observations about the first opioid epidemic is the fact that the demographics of the population were predominantly white, native-born, middle and upper-class women, mostly housewives, mostly concentrated in the South. There were male addicts in this demography, but the epidemiology tells us that they were primarily the physician population that had prescribed these opioids for all manner of ills that middle-class women who could get medical treatment got. So it was a treatment for headaches, for pain, It was a treatment for to help with delivery. It was babies. It was a treatment that was overused. My point that the physician population overprescribing opioids, with the exception of the incidence among Chinese migrants, was predominantly responsible for the opioid epidemic in this early period. This meant that simply treating the first opioid epidemic with federal laws that affected the supply, that is, the physician's prescription, worked. It worked like a charm. We didn't need to criminalize any more than the supply side. That's why we had the Harrison Narcotics Act of 1914 pass. We prohibited the manufacture and importation with the Heroin Act of 1924. We disrupted global supply routes, and we were successful. Remember, in this slide, you see that by 1944, the number of opioid addicts was nearly non-significant from a scientific point of view. That's the first opioid epidemic. Let's look now at the second opioid epidemic in America. It was between 1960 and 1980s. Very different. This opioid epidemic, again, focused on opioids in this period, formed a different demographic population. This was predominantly male, predominantly in city centers. Predominantly those affected by this opioid epidemic were low income, were Latino and African American. And while there were some upper class suburban whites affected, the majority of the white population that was affected was very poor. There were Vietnam veterans. There were people who had used and become addicted quickly, either while in Vietnam or when they returned. My point is that the demographic was a socially less influential, less well-represented population, whether it was urban Blacks and Latinos or poor whites. The prevalence of addiction was not in the upper classes, not in the predominantly well-heeled middle-class population, and therefore, my argument goes, our interventions changed. Our interventions focused primarily on criminal law enforcement. Our interventions focused somewhat on government-sponsored addiction treatment, but not very much. There was not very strong focus on treatment. As a result, you will find very senior addicts from this population still living and struggling today. Treatment was not the priority. We instead regarded this as a criminal law enforcement issue. The rise of the opioid, in this case, heroin addiction problem, really was not treated as a public health problem. It was treated as a criminal justice problem. So fast forward today to where we are today, starting in 1999, in Texas, in the United States generally, the third opioid epidemic is upon us. We are still struggling with it, even though these data only go up to 2015. The source that I've cited here, the Kaiser Family Foundation, is a very good source for updating these data, and you see that the trends are still increasing, and they're increasing among white, majority male, majority young, middle class, and poor populations. This is a different population. It's a different opioid epidemic than the first at the turn of the century, the second during the 1960s, 70s, and 80s, and now this third. The prevalence is that now 11.8 million during the year 1916 have misused at age 12. Or older. Starting at age 12, these are our data. And the overdose deaths are climbing exponentially. Our interventions have been inequitable. That's my message to you today. Our interventions have been inequitable. How do I know this? We have continued to treat this opioid epidemic more as a criminal justice problem with mass incarceration, with increases in our prison population, than as a public health problem. And my thinking, my hope, is that today I will encourage you to think of the ways that the disproportionality, the disproportionate impact of the laws that we are using on the very communities that are already suffering inequity can be corrected. There are other ways than criminalizing our community members who are victims of the opioid epidemic. There are other ways to treat this. We can look at policing reforms. All right. These are data that tell us that the use of marijuana between Black and white adults is almost equal year over year. Here from 2001 to 2014, if you look on the left, I will tell you that updating these data does not improve the disparity. So the line that is light colored shows the incidence and use of Black adults for marijuana. This is not opioids, but this is marijuana. We keep the data for marijuana more comprehensively. And for whites in the dark line. So again, on my left, perhaps your right, you see that the tops of the lines are very close. I will say updating this data through 2019, the most recent year that I have the data for, the lines get even closer. What does that tell us? That Blacks and whites use marijuana at about the same rate. However, consider the data on the right. Blacks and whites arrest rates for marijuana violations throughout the nation. The reason I suggest that we can consider policing reforms is we look at how better to treat the opioid epidemic is because of the wide disparity between the incidence of Black arrests, that is shown by the light blue bars on the right-hand graph, and white arrests for marijuana violations on the left. Those disparities have been important in exacerbating the disparities among us, among our communities that have suffered from the opioid epidemic. Secondly, we can look at sentencing reform. I will say here that in Texas, there is an example of a law enforcement assisted diversion program. Police protocols that divert people away from the criminal justice system is exemplified in this program in Bexar, Texas. There are other places, Clayton, Georgia, but we could see more widespread use of these much more creative interventions if we wanted to treat the opioid epidemic differently. And we should do this. We should do these changes because these are likely in the last 8 years in Texas to improve not only health outcomes, but social outcomes. They are likely to extend what I call the public health frame that we used prior to the 1970s, that we used in the first opioid epidemic, and reach back to renew and revise the kinds of legal approaches that we have used and shift them not to criminal justice, but to shift them to a public health intervention. I could say more about this, but I'm going to skip to one other intervention that I feel very strongly about. Substance use treatment for incarcerated victims. Those who are offending have offended and tested positive for opioids are people who need treatment as well as any other retribution or incarceration that has affected them. Treatment is a missing element of our toolkit, if you will, for the fight against opioid addiction. We need better reimbursement rates supporting not only medical care, but access to employment training, education, mental health services. An example is from Arizona here. Mercy Maricopa has a wonderful way of treating opioid addiction. A workforce improvement. I don't know if you have a ban the box policy in Texas, but prohibiting that is an important way to improve our treatment of the opioid epidemic. I have one last suggestion, and that is to improve our workforce policies. Here we have an example of the unemployment rates that separate Blacks and whites. Latinos similarly can be shown in this national data. But let me show you something very, very important in a potential data-driven, evidence-based intervention that could help address opioid addiction in Dallas County. These data show the effect of employment and wage growth on overdose rates by opioid users, by substance use dependent opioid users. I've highlighted the numbers that reflect this conclusion from this important study, and that is we see a decrease of over 50% of overdose deaths in metropolitan and non-metropolitan areas that increase the wages available and the number of low-wage jobs that are available to the community. This number shows that when industries that are more likely to employ lower educated workers grow faster, overdose death rates decline. A simple way of saying this is that deaths of despair happen because people despair. And we can improve the mental health of our communities if instead of looking at these communities through lenses of bias because of who they are economically, who they are ethnically, who they are by their immigration status. Remember, those biases that I suggest are influencing doctors, influenced me in my story with the cab driver. They also influence our policies. And we can do a better job if we address mental health, recognizing it is a public health problem that should not be seen through the lens of our implicit biases. That concludes my comments on just medicine. I'd like to turn now to addressing structural inequalities through just health. One more story at this time will help set the stage for the remainder of my comments. I'm showing here my parents. May and Vincent Bowen are not remarkable for any of their accomplishments. My mother graduated high school. It was a vocational high school, so she was always well dressed because her high school major was fashion design. My father also graduated high school, but didn't get his BA until I was 6 years old, or 5 years old, I think. I have a wonderful picture of him graduating in his regalia with his BA, which he got at night from the City College of New York. And so these weren't well-educated people, but they're shown here. My father is age 48 in this picture. My mother is age 47. By the next year, my father is dead. My father died at age 49. My mother died younger than I am today. All right, I'll just leave it at that. But she died very, very young. And I want you to hear their stories to give a personal evidence, a personal picture of the structures that I contend, contributed to their deaths. My father worked 4 jobs, and he worked them because the wages available to people who lived in my part of New York City, lived in the South Bronx, where predominantly Black and Latino populations, exclusively Black and Latino populations lived, are characterized by low-wage jobs. So in the mornings, he'd go to work as a real estate banker once he got his BA, and in the evenings, he'd come home at 5 o'clock, take a 3 to 4 hour nap, and go back in the evening on the same subway he rode down to the bank, but this time he was driving it for 8 hours. He did that for enough years. Why? Because the educational opportunities available to me, my brother, and all of those who lived in the South Bronx were substandard. If I had graduated from PS 123, the intermediate school that was the one I was assigned to as a public school, I would not be standing here today. I know this empirically and I know this anecdotally. I am standing here today as Dean of GW Law School. I went to Harvard, I got a PhD, I did all of these things. Why? Because my father worked 4 jobs to make sure that he could pay the $4,000 a year of the $40,000 price tag that was on my education at the private school 7 miles away from where we lived. I went to private school from 4th grade on. My private prep school changed my life. Those of the families that are in the South Bronx still, my book Just Health highlights, have had nowhere near the success that those 4 families in my social circle who got their kids out of the South Bronx have experienced. But of those 4 families, none of us had our parents. I believe this is structural. I believe our families are not dead because they were overweight, because they had high blood pressure, because they had comorbidities. I believe they're dead before their time because of the low wages, the substandard education, the segregation that concentrated poverty in the South Bronx, the violence that required us to navigate day in and day out the South Bronx dangers. So instead of having a street on which I could jog or a tennis court on which I could play, I had to navigate drug dealers and so forth. These are the environmental hazards, right? Not to mention the fact that the South Bronx is called Asthma Alley for a good reason. It has the disproportionately high number of highways. I crossed 3 interstates when I went to my public school from grades 1 through 4. 3 interstate highways worth of carbon monoxide. I should say fumes because I'm not sure it's carbon dioxide or carbon monoxide, but the dangerous fumes from cars being inhaled by me and my peers. I was located near the highest concentration of waste transfer stations in New York City, in the South Bronx. My area, like Flint, Michigan, had no supermarkets that were a part of any chain. We had bodegas, we had convenience stores, but these are structures. Why are they structures? For 2 reasons. One, they impact several different sectors of the economy and society, and they do so, number 2, consistently across the country with the same populations: African Americans, Latino Americans, Native Americans, and poor whites. We call that structure because it can be replicated over and over again. We see it in nations. Here, the difference between top earners and the bottom earners in any country is wider as you go to the right of this graph and narrower as you go to the countries on the left of this graph. So we say income inequality in these nations, as measured by an index that calculates the difference between top and bottom earners, is greater to the right. My arrow shows where the United States is. That inequality by income is exceeded in the United States only by Turkey, Bulgaria, Mexico, Chile, Costa Rica, and South Africa, and is higher not only in the United States than all of those to the left, but correlates directly with outcomes for health and social measures. This is an important graph. Let me pause here and explain it, because it is why I call inequality structural. So that Gini index that I just described that measures income inequality, the distance between high and low earners, is on the bottom x-axis of this graph. On the y vertical axis of this graph, we have cross-tabulated, not me, but Wilson and Pickett, the authors of this study, have cross-tabulated outcomes of health and social measures. So they have an index saying how big is the disparity between Black, white, and Latino deaths due to heart disease, due to lung disease, due to cancer. How big a difference is there between educational attainment, meaning BA or high school graduation, among Blacks, whites, and Latinos versus others. Those measures are compiled in an index on the left side. And what you see here, stay with me here, this is very important. What you see here is the more inequity there is in a nation, the greater their social problems are, the higher their index of social outcomes, right? So the greater the distance between the haves and the have-nots. In Japan, very narrow. In the United States, the widest of all nations studied in this study. It correlates directly to the poor health outcomes and the poor social outcomes that make us think about this picture. We say structures because we see not one fish on the ocean floor or on the beach having met its fate. And you walk along, you see one dead fish and you think, okay, that dead fish had a problem. That dead fish met a predator, had a disease, swallowed plastic. That one fish is the problem, and the problem lays with that one fish. When you see structures that produce schools of dead fish on the ocean shore, you think not something's wrong with the fish, but something is wrong with the ocean. And it's that ocean that creates the structural view that I'm asking you to consider. More even than that, I'm asking you to consider how that structure disproportionately affects minoritized populations in Texas as well as in the United States. How much time do I have left, please?
Yeah, 15 minutes, but if we wanted to leave like 10 minutes of questions at the end.
All right, so I will wrap up in 5 to 7 minutes, and then I'll give us time for questions in the end. So let me talk about this term structural racism right now. It's best exemplified here in the outcomes by race and ethnicity. In the COVID crisis, you're aware of these data, but let me suggest the ways in which they have to be addressed. I'll use this last story as my wrap up for how to address structural inequality that produces structural disparities in Texas as well as in the United States generally. So this is a picture of Flight 1549. It left LaGuardia to go to Charlotte, North Carolina in January of 2009. If you saw the movie Sully, you know there were 155 souls on board. They all made it. But if you look here closely, this landing on the Hudson River, they hit a gaggle of geese and they landed on the Hudson River, had to have an emergency rescue. January in the Hudson River is freezing, freezing cold. It's frigid. You look closely at this picture and you see that of 155 souls, they were in 2 separate groups. There was a large group on the wing of the plane standing, and if you look closely, the water's starting to lap up around their ankles. There was a small group in the front of the plane, and they were in life rafts. Because they were in first class, they had life jackets when they met disaster. They had flares to call for help. They had food to eat. Not so with those on the back of the plane. This is to tell you that the justice that will create health equity in Texas as well as in the United States. The justice that will create a just nation must address the disparities in place that people are born into. The life chances of those on this plane in the wing area are much lower than the life chances of those in the front of the plane. And in order to have a just nation, we must live up to the promise of equality and justice under the law for all people. So now let me just suggest some ways in which this could happen. Your role in bringing this justice to pass, of course, I am going to give you ways in which the law can be used. Are they the only ways? No, but I am a lawyer. I'm a law professor. I'm a law dean. These are some of the ways in which law can be useful to you in bringing the equality of opportunity in the areas that affect health, right? in the areas that have to do, remember the plane, with where people are located in their life's circumstances. My parents, where they lived affected the structures that were available to you. So litigation is a solution. I'm not suggesting that it's the best solution, but it is a solution. Fighting for equal access to healthcare and education. We desegregated hospitals by this seminal case, the Moses H. Cone Memorial Hospital case that was prosecuted by 3 dentists, 6 physicians, and 2 patients, is responsible for desegregating over 7,000 hospitals. I wish I had time to tell you the story. This case was brought, it was appealed to the Supreme Court. When it was appealed, literally in the dead of night in Greensboro, North Carolina, the staff of Moses Cone Hospital rolled their patients out into the street, mixed them up so that they were no longer segregated, rolled them in. We didn't need a march. We didn't need dogs like we see in this picture. We didn't need a federal, we didn't need federal marshals to come in. We just needed litigation to show that this country would no longer tolerate segregated hospitals. We can do the same in the case of addressing health disparities. Another solution is legislation. Title VI of the Civil Rights Act is one of the most important pieces of legislation that has been passed to prohibit discrimination. And it was passed at this price. I showed this picture to remind us the cost that people paid in order to get that legislation, in order to create an opportunity for legislative solutions. This federal law makes it possible for Texas and every other state in the United States to pass and enforce equal equality, equal protection laws that prohibit discrimination wherever public funds are used. Besides litigation, there is a way in which advocacy, here, not just litigation, please allow me to correct this slide. Advocacy is what I'm really suggesting. If you're not a marcher, maybe you're not a marcher like these physicians and clinicians, but maybe you could do what I saw so many do when I was in the senator's office that I worked in as a health policy advisor. People just come down. This is an amazing country. Come down to Washington, D.C., walk into the Hart Senate office building or any of the Senate office buildings and ask to speak to their legislatures and ask for legislative solutions that will help reduce health disparities. Instead of having to endure this kind of affront, there are administrative solutions. We have Section 1557 of the Patient Protection and Affordability Act. This is an extremely effective way to do administrative complaints that will help equalize health disparities. I'm going to suggest that litigation by Title VI, I'm going to suggest that addressing poor housing, segregation, substandard neighborhoods, the affordability of housing, I'm suggesting that your concern should be improving the schools and reducing the disparities in funding in schools. And all of these would address structural racism. It would address the differences between Blacks, whites, Latinos, poor whites, and outcomes. It would address all of the concerns. I'm going to end with one that you might not expect. If we address the disparities in law enforcement, in racism, that particularly address children's health, we will make a huge difference in the outcomes for many years to come. All right, let me conclude by just showing you that a partnership between medicine and law, a partnership between policymakers, social workers, that include law as one of the tools, is the way that we will make a difference. Pay attention to the way that you vote. Recognize that health is a byproduct of justice. And when we have justice, we have a way together, just like these trees, which are actually not individual organisms, they're connected underground, are strong because they stand together. We can do the same. Thank you for your attention.
I don't know if anybody online has any questions. I think Commissioner Price wants to say a few
Yeah,
words.
first of all, Doctor, thank you very much for your time and for a class that those individuals who are in camp that would have really benefited from this reflections on health equity. Some of the presentation in terms of ban the box, Dallas County did that years ago. Number two, with regards to the latest opioid epidemic, Dallas County was one of the first in this state to engage and have begun to receive the residuals of that appropriation. We have now begun to, we're on the streets now with an RFP as we dealt with the community. Parkland, who is the public hospital here, comes under the commissioner's court through a board of managers. And Parkland is our partner, unfortunately, in the second largest custody in this state, which is Dallas County Jail, and the ninth largest in this country. As such, Parkland is our partner in the handoff with regards to opioid treatment as we hand off those individuals who are in custody going back into the community. We also, in collaboration with the North Texas Health Behavioral Health Authority, which is about mental health. And I happen to chair that along with public health. So I understand all of these and I just appreciate that. I happen to, with my colleagues, author the commissioner's court resolution on the declaration of racism as a public health crisis. Never thought it would have passed, but it passed, and the court has begun to deal with what I consider to be substantive matters to deal with that. I guess I did not hear you talk about the difference in so-called African American middle class health disparity and what goes on with what we consider to be marginalized or low income health disparities, because all of the numbers basically dictate that there's no real difference in those health disparities. And so I would love to hear your comment. And of course, in the cone matter, I had never heard that. I would love to see who was the delegation of lawyers. You talked about the clients, the dentists, the doctors, the nurses, but did not talk about the legal staff who brought that sound like a class action to bear.
So you got me on the lawyers. I have to look that up. I'm not sure who brought the Moses H. Cone case. It was in the Fourth Circuit. And while the next question comes up, I'll look it up and I'll be able to come back to that answer. Let me, though, spend a little bit of time on the really interesting data. You're obviously very, very knowledgeable. I'm not telling you anything that that you don't know, and also already making so many of the recommendations real on the ground there in Dallas that I have shared with you. So I'm humbled by anything I can add to be helpful to you. But what you've raised about the lack of difference or the sameness, if you will, between middle class and lower socioeconomic status, SES status, that means income, education, and work level. The lack of difference between their health outcomes and the inequality or the higher and lower levels of income is remarkable. It's very important to recognize. I'll use maternal health outcomes, for example, or let me try, I bet infant mortality is also familiar. Either one will work, but let me suggest to you that a African-American woman will lose her baby in the first year of life more frequently in the nation, as an average 2.5 times more frequently, but in some parts of the nation as much as 11 times more frequently than a white woman. And that will be true even if the African-American woman is college educated and making what we consider a middle class a salary above $75,000. And the white woman is a high school dropout living below the poverty line, right? This is one of the ways in which we show that a race problem exists with respect to infant mortality. Same with the data with respect to maternal mortality, the ways in which a mother who is Latino or African American, slightly different for Latino women, but African American women is the largest difference. Middle class does not help with what the disparities are in these health outcomes. That's an important observation because it eliminates the argument that all we have to do is control for income. Income doesn't buy us better infant mortality or better maternal mortality outcomes. And this tells us that there's something salient about race qua race, race as race, that defines the differences in medical treatment, that defines the difference in, we think in part, something we call the weathering hypothesis. That is the difference of the stress that is associated with living as a minoritized member of a minoritized population in the United States. That stress, remember my Lyft story, right? Remember I said when I got in the cab, I had a weekend where I was unkind to my family. I was on edge. I was stressed. This has been measured as something that is called the allostatic load, right? That my having to weather that experience, whether it was really racism or not, the imposition of stress had a biological and physiological impact on me. So these are some of the explanations that we think will help us unpack why infant mortality, no matter what the socioeconomic status of the Black population is worse than whites, and maternal mortality. I hope that answers your question.
It does, and you appropriately. I don't want to take up all the oxygen in the room. I think there's someone else that wants to speak to. Is there another question, Aaron, that's online? Will you please share it? And I think Todd Furness, who is a member of our Parkland board, is also on the line. He authored the 60% Solution, Rethinking Healthcare. He happens to be on our Parkland board, which again is the public hospital and part of the substantive presentation. You want to get it together? I'm just trying not to take up all the oxygen. It's interesting as they get that doctor that one of the things that Todd does in his book, he talks about just even medical schools and what has happened to medical schools historically in this country. Black medical schools, let me back up. Black medical schools. And so we talk about, while we talk about all these initiatives, I'm sure they're in Washington, the community health needs assessment, which we've embraced here, talks about the difference, 23-year difference between North and South, where we reside. And so, what you're doing is affirming what those reports have said and what we are trying to address through just not policy, appropriations, but also culturally. Was it Serena Evers and her baby?
Serena Williams, yeah.
Yes,
Yeah.
the same kind of outcomes. Jason, y'all got them on. I don't want to just keep talking.
Yeah, so
Okay.
someone online, Beatrice Greenwood asked, health disparities seem to start at the beginning of one's lives, where they live, education, job opportunities one has. I agree with that. Start at the beginning.
Try to read that again, Jason. I don't think she could hear you.
Yeah, so Beatrice Greenwood asked, health disparities seem to start at the beginning of one's lives, where they live, education, job opportunities one has. Would you agree with that? And I guess what do we do since we have to start at the beginning?
Yeah, I do agree with that. I do believe that one of the reasons I highlight education in my comments is because I have a strong view that there are three social determinants of health, three things that have nothing to do with access to healthcare. That's important. Have nothing to do with whether or not you're insured. That's important. Let's assume that those things are very important. However, that have everything to do with the social circumstances in which people live that we can do from the very beginning of life to help a child's life chances be better. Number one, give them affordable, stable housing. That is correlated with better health outcomes. Number two, give them access to early education and an opportunity to graduate high school. If you graduate high school, the data tell us you survive life better and longer, right? To graduate high school. So our educational reforms, if we can close the gap, I don't know what it is in Dallas County, but nationally, the gap between funding for Hispanic and Latino, predominantly predominantly Latino and African American school districts in the United States is $23 billion with a B, billion dollars large when compared with predominantly white public school districts. We can start closing those gaps so that the resources for advanced placement courses, for college counselors as opposed to police officers in school, right? For after school programs that are, and before school programs. I mean, you don't want me to get started on whether we have enough, for example, coding courses. In my, this is a personal story. I'm on a detour. I'm going to go very fast, but my daughter is a software engineer, and she loves to teach that to students from underrepresented background. So she, went into her local public school and offered a coding course before school. So it would start at 7 o'clock, go to 8 o'clock, and she got tons of kids to sign up. Now this is a predominantly Latino school, and all the kids that signed up were white. Why? Latino parents had no way to get their kids to the course before 7 o'clock and then get them to school because there was no transportation. They were relying upon transportation that started after. So the kids that needed it most didn't have access to it. She went to the school board. She got a bus van and approved, and she met some resistance from white parents. But you see, the resources that are available early on in life make a difference. They make a difference in health outcomes. They make a difference in educational health outcomes. And we have to start at the beginning. So the three differences: housing, education, and income. If we can pay families. Yeah.
Transportation.
Yeah. Yeah.
And it's interesting, and I know Jason is trying to he's navigating this, but in Dallas, it's 955 square miles. I have 70% and 40% of my district is transportation challenged. We rely on buses, unlike you guys with subways, et cetera. We rely on public transportation, and I find that interesting and in most of our communities. And so I just want to say again, thank you. I understand that Jason has another part of this, and I'm trying again not to, even though as I say this, I continue to hog the mic. But one last thing, a person who is a part of my committee asked me to say, policy changes take time. What onus does detailed population disparity reporting to boards and the public have on change? Report cards on quality care access and results seem crucial to push for policy change, yet most don't know where the data lives.
Yeah. I could say I could not concur with that more. If you can't measure it, you can't change it. And accountability depends on being able to tell people what your outcomes are on a regular basis so they can react to the data. So I agree with that. I mean, we could talk for a long time about what to do with data. I do want to get in that Jack Greenberg, I can't believe I didn't know this. Jack Greenberg and the Legal Defense Fund from the NAACP brought that case in Moses H. Cone Hospital.
Thank you so much again, Dr. Bowen Matthew, and thanks everyone for joining us today. It will be available on the YouTube, and so for those of us that are going to be joining us for the rest of this conversation, it'll be in the Teams invite that you should have got an email. We just for everyone to know, we're having a roundtable conversation with a few healthcare leaders here with Dr. Bowen as well. So. Again, thank you very much.
Thank you. Thank you for having me. I appreciate it very much.
Thank you. Thank you.